Good afternoon, and welcome to the Lung Cancer Institute updates in 2025. We have important information that is really relevant for everyone, whether you're a patient, you're a family member or friend of a patient, or just for your personal awareness. Our physician panel series are meant for everyone. Today's topic will be navigating prostate cancer, treatment options, and managing the implications of sexual dysfunction. We will be learning from our esteemed LCI physicians, Dr. Taub, the surgical oncology urologist, Dr. Michael Casper, radiation oncologist, and Dr. Spencer Backow, our medical oncologist. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, and our latest technology will truly save lives. As we're seeing today, we will also learn about the benefits of our multimodality method of treatment. All combined is what we're able to offer you. In the interest of time, our speaker's bio was sent to you by email. During their presentation, we invite you to please take notes. And if you have questions, please put them in the QA box or the chat box, and they'll have time at the end of the presentation to address any of your questions. So thank you. We're very happy that you have joined us, and we will start with Dr. Taub.
Good afternoon. Thank you for spending a little bit of your Friday with us so we can share what we do with you. I'm very, very fortunate to be joined and be a participant with Dr. Casper and Dr. Backow on this panel. They're terrific physicians and very accomplished physicians, so I'm honored to share the panel with them. And we really have a unique comprehensive approach to prostate cancer care, and we strive to meet each patient where they are in their cancer journey and bring them in as early as possible so we can try to make sure they're cured. So I'm going to move forward. So here's our overview of what I'll be talking about. Just a little bit about prostate cancer, about screening for prostate cancer, which can lead to higher cure rates, less mortality, and overall longer life for our patients. We're talk about surgical treatments. We have robotic surgery and new focal ablation. And finally, we'll wind up on managing implications of sexual dysfunction. So, this is what I do. I'm a urologic oncologist. We deal with adrenal glands, kidneys, ureters, bladder, prostate, and testicular cancer. Prostate cancer is the most common cancer in American men. There'll be over 300,000 new diagnoses of prostate cancer in the United States this year, and it is the second leading cause of cancer deaths in the United States. Over 35,000 men will die of prostate cancer this year. The leading cause is lung cancer. So the prostate gland has reproductive function in men. It contributes nutrients and fluids to semen, so sperm can impregnate a woman's egg. The urethra, or the middle of the urinary tract, runs right through the prostate. And so as the prostate grows with the aging process, men develop some urinary and sexual dysfunction, and that is much more likely to be from benign growth of the prostate rather than cancerous growth of the prostate. So really, screening is with a blood test rather than symptoms. So average age at diagnosis is 66 years of age. 1 in 8 American men will be diagnosed in their lifetime. Specific risk factors that require a bit more attention, a bit earlier screening. Men with genetic mutations, particularly the BRCA gene, is very well known. The breast cancer gene that is talked about in women also is associated with a much higher risk of prostate cancer. Strong family history of prostate cancer in father or brother, especially under the age of 65. African Americans are more likely to get prostate cancer at a younger age and more aggressive form of prostate cancer, and older men are more likely to get prostate cancer. So still, older men who are healthy, we screen them up till at least a 10-year life expectancy. We've seen a decrease in mortality from prostate cancer from around 40,000 deaths per year in the early to mid 1990s, down to lower than that. And that's, again, directly related to screening. With the PSA blood test, we can detect cancer at an earlier asymptomatic stage, which yields a much higher cure rate. So the American Cancer Society, the American Urologic Association recommend screening for men aged 50 to 75 years of age with a life expectancy of at least 10 years. In our community, we have very healthy 80 and 90-year-olds, so we push the screening sometimes into 80 or early 80s. And for higher risk patients, it is recommended to start earlier, 5 years or 10 years earlier, never really before the age of 40. Your primary care physician will take a medical history, a family history of those of your relatives who have prostate or breast cancer or other associated cancers. We see colorectal or pancreatic. They'll do a prostate examination, get a PSA blood test. If any of these are abnormal, you'll be referred to a urologist for additional evaluation. At our institution, all of the men we see get an MRI before doing prostate biopsies, so we can be much more precise and directed in our biopsies. So MRI of the prostate is the first imaging modality to actually be able to see the cancer. MRI has been around for 50 years, but just like the phones in our pocket are so much more powerful today than they were before, the software and hardware updates to the MRI scan allowed us around the year 2015, so about 10 years ago, to truly detect areas in the prostate that are of concern, and then we can focus our biopsy. There's a high-RADS grading system similar to a BI-RADS grading system for breast cancer on a 1 through 5 scale, and those with a 3, 4, or 5 really should undergo biopsy. So MRI fusion biopsy is a much more precise biopsy. So we use the stored MRI images that were obtained before the biopsy. We use a transrectal ultrasound, which is a live image, and we merge these together so our biopsies can be more precise. There's been shown good level 1 evidence that higher detection rates for aggressive cancer, and then we can minimize biopsies, and we have less detection of low grade or non-life threatening cancer. We also use a micro ultrasound. So we're one of few institutions, thanks to the philanthropy of a very generous Sands family, that this has the power of the MRI in our hands. So it's a transrectal ultrasound that is really able to visualize the prostate in a way that is similar to MRI, so we can be much more precise again in our biopsies. So treatment options depend upon the grade and stage of the disease, so how aggressive it is, the volume of cancer, did it spread anywhere, the patient's age and overall health, and patient's personal preference. Prostate cancer, very sensitive discussion. Treatment options can really affect urinary function, sexual function, and bowel function. So incorporating the patient's desires is very important. And then we have genomic testing, which allows us to personalize the treatment to the patient's specific cancer diagnosis and degree of aggressiveness. So this is a tissue-based test which provides more precise and individualized information about the biology of the tumor, looking at the DNA of the tumor, RNA of the tumor. Testing is performed on the existing prostate tissue from the biopsy. No additional procedure is required. It goes from a scale of 0 to 1. You can kind of see that the higher the number is considered higher risk and lower low risk, and it gives us just additional more information from the biopsy. The pathology is looked at and is more subjective, and this is a bit more objective information. So I'm sure Dr. Casper has some better pictures of Lynn Cancer Institute, but this is a building that we're fortunate enough to work in, and our patients are fortunate to come to. It's a beautiful building, and we all collaborate here for our multimodality urologic oncology clinic. It's every Wednesday afternoon where we see patients with new and difficult cancers, and we knock our heads together to come up with the best options for them. So we have great medical oncologists who have immunotherapy, chemotherapy available, and clinical trials. Dr. Spencer Backow and Edgar Castillo. Our radiation oncology program is very robust. We have a multitude of radiation options and are getting proton therapy. In just 6 months' time, we will be treating patients for prostate cancer with proton therapy in our building. We have genetic counseling with Dr. Morel. Our radiology is very specialized with MRI, PSMA PET scans. We have a fellowship trained pathologist in Dr. Salim Umar, and we have wonderful ancillary services, nutritional support, social work support, and clinical trials. So surgical treatments for prostate cancer in 2025, our traditional surgical approach for radical prostatectomy uses robotic technology, small incisions, less pain, less trauma, less bleeding, and just overall quicker recovery. We have new surgical techniques, including focal ablation, which we'll go over. But first, just want to touch on active surveillance. It's not radiation, it's not surgery. In fact, it's really just keeping an eye on the cancer. And studies have shown that early low risk prostate cancer is safe to watch and keep a close eye on, and obviously has the least side effects in terms of sexual, bowel, or urinary function. So good European studies have shown that at 15 years for specific low risk disease patients, there has been no change in mortality when you compare surgery, radiation, and active surveillance. There's a slightly higher risk of developing metastatic disease, but this can be mitigated with close monitoring, repeat MRIs, repeat biopsies. So we do advise that in some of our patients. Prostatectomy is really the gold standard treatment for prostate cancer care. The prostate is removed. It is able to be looked at under a microscope. We get much more information in terms of, is there seminal vesicle involvement? Is there a lymph node involvement? Is it outside the capsule of the prostate? Very high cure rates, and it is recommended for younger patients with more aggressive disease. If we detect the disease early enough, we're able to preserve urinary and sexual function much more acutely with the robotic technology. So a quick overview of the Da Vinci surgical system. It's a computer-enhanced surgical system where the surgeon operates at a console immersed in a 3D magnified surgical field, and you have the assistant at the bedside to suction, push in suture material, and that sort of thing. The instruments are you can see how small the instruments are. They fit through dime-sized incisions. The bottom picture shows a wristed capability. So it really acts and mimics a human wrist. So you can get in very, very small quarters, very tight spaces with precise maneuverability, increased dexterity, which allows us to accomplish exactly what we need to do in removing the cancer and preserving normal functionality. Then lastly, there's focal therapy. So with advanced imaging techniques, PSMA PET scans, MRI scans, with targeted MRI fusion biopsies, with genomic testing, we are able to really accurately characterize the patient's disease status, risk stratify the patient, and personalize their cancer care. So patients who are seeking kind of an option that's between monitoring and radical or whole gland treatment with surgery and radiation, um, focal therapy provides a safe and effective, minimally invasive way to deal with intermediate risk disease. This is for select patients who have low volume intermediate risk disease, not more aggressive disease and not more advanced disease. And we use it for salvage therapy in the rare case of radiation failures. So this is the diagram at the upper left kind of shows a picture of what we try to do. So we try to treat the dominant, we call it the index lesion that has the cancer that shows up on the MRI, but it's really for cancers again that are intermediate risk, that are localized, and the whole idea behind um, uh, focal ablation is that you're treating less of the prostate, so you're preserving more functionality in terms of sexual and urinary function. And it truly does limit the toxicity. There's a new study that was released in the European Journal of Urology in December of 2024 that compared um, HIFU, which is high intensity focused ultrasound. I'll talk about that next, is a focal ablative technology to prostatectomy. And over 3 years, the disease free survival or the risk of recurrence was similar for prostatectomy as compared to HIFU. And the overall urinary and sexual function was much better with the HIFU focal ablation arm of the trial. This is the treatment modality we use. HIFU again stands for high intensity focused ultrasound. Basically, sound waves are projected through the rectal wall and directed at the area of the prostate. It's one little focus of energy at a time, sculpted, layered on top of each other, sculpting out the area that we want to treat and preserving the remainder of the prostate. This is a picture on the bottom left of our group. After our 50th case, we finished a few months ago. There are only 3 of these new machines in the state of Florida, University of Miami, University of Florida, and Boca Raton Regional Hospital. So we're fortunate to be able to offer our patients a truly comprehensive cancer approach with adding proton therapy, with all sorts of different radiation therapy, robotic surgery, focal therapy, and Dr. Backow and Dr. Casper will talk about also advanced disease with Pluvicto, radioligand therapy that targets areas outside the prostate. Finally, we've come to talk about side effects. So the most important thing to know about prostate cancer are that there are options, and we share the decision-making process with our patients. We talk about, the extent of the disease, the grade and the stage of the disease. How aggressive is your disease? How much cancer do you have? Is it localized to the prostate? Has it pushed into the seminal vesicles? Where is it? We talk about our individual patient characteristics. What is their life expectancy? What other diseases do they have? How is their urinary and sexual and bowel function right now? Do they have any bowel disease separate from the prostate that we need to take into account? And then patients come with their own specific desires and goals. Everyone wants a great oncologic outcome with a cure and with a great quality of life. But when weighing these factors, what's more important to each individual patient? And sometimes the disease dictates what we have to do. We have to remove the prostate gland. Sometimes there's really a whole slew of choices. And so we sit at the multimodality clinic and we go through these options one at a time and help guide the patient to what the best treatment option is for them. Ultimately, as urologists, we manage sexual dysfunction after prostate cancer treatment, and that's after surgery, after radiation, after focal ablation, uh, after hormonal treatments that Dr. Backow may introduce. And there are a slew of treatments. There's oral pharmacotherapy, the Viagras, the Cialises that work very, very well. And there are more mechanical solutions such as a vacuum erection device. There are injections with more potent medications, and ultimately a penile prosthesis that we have local experts that can, such as Dr. Syed, who can um, do surgery for that. So there are a lot of options for uh, maintaining a healthy sexual life after prostate cancer care, and we uh, can help patients through that process. But the most important part is making sure we cure them of cancer. And so, without further ado, I will let Dr. Casper share his toys for curing prostate cancer.
We can
Right,
see.
I'm Michael Casper from Department of Radiation Oncology, and I'm going to talk a little bit about radiation. And Dr. Taub talked a little bit about our multimodality clinics, and I always like to include this because it's what really sets us apart. So, good medicine, especially top-notch cancer care requires not only having the best technology, which we're really blessed here because of such great support from our foundation, but also hiring the best people and then providing them with the opportunity to work with other top individuals from other medical disciplines. And the multimodality clinic allows us to do just that. We have site-specific cancer surgeons, medical oncologists, radiation oncologists, as well as radiologists, pathologists, psychosocial experts, and dietitians who all meet with the patient at the same visit and then gather together and discuss the patient's case. And again, as Dr. Taub mentioned, shared decision making is what it's all about. I also like to say a word or two about radiation because many people don't know much about radiation. And although it's the single most utilized agent in oncology, it's frequently it's not well understood, not only by patients, but even many physicians. For this reason, sometimes it's underutilized, especially despite being a very high value and efficacious treatment for cancer. You can see that it's 40% of all cancer cures are primarily due to radiation. But it's also important to note that where you receive your radiation can make a big difference. Small changes in radiation delivery can have a huge impact in the clinical results. So changes in dose impact field size expertise. And of course, you can say this in all areas of medicine, but I think it's particularly true for radiation. One of the exciting new developments at the Lynn Cancer Institute that, again, Dr. Taub mentioned, is the arrival of proton therapy. And while the current feeling is that it may not be a game changer or even significantly better than current radiation modalities for prostate cancer, there is likely a role when we're treating prostate as well as the pelvic lymphatics. We'll be better able to avoid some of the bowel, and we do believe that that's going to make a difference. The primary benefit from the physics standpoint is this little blip in the middle here for protons. That's the Bragg peak. You can see the dose comes in at a relatively low area, and then you get that little bump, and it delivers all of the radiation right at a certain depth. And on the above line, you can see what typical X-rays do. We come in at a little higher dose in the skin, and then it slowly degrades as it goes through tissue. It's attenuated or absorbed, and then you get this extra dose of radiation through a lot of the tissue. And the goal of proton therapy is to avoid that. So you have less of what's called an integral dose. Okay, so there's less total dose given. The trick is, trying to figure out exactly where this Bragg peak is going to be deposited. And we can do that fairly precisely, but there is a little bit of an uncertainty. So we can actually do a little bit better with X-rays in being the most precise despite the fact that we're going to get a little bit more low dose bath outside. And you can see on the cartoons down below that with photons, you get this entry dose and exit dose. And then on the right side, you see the entry dose and then virtually no exit dose. Now, this is a simplification, of course. With photons, we come in from many, many different directions. So the surrounding dose and the exit dose is minimalized. So that's a bit of a simplification. But that's the basic tenet of proton therapy. This is our proton machine. It's already in place. We're getting it up to snuff right now. All the bells and whistles are being fine-tuned, and we should be ready by March of this year. And here's the picture of the building. You see off to the left, this new building on the left here is the Proton Center. So we've had to build an entire new building for just that one machine. Pretty impressive. And this is the front view from 13th Street. You can see that the whole cancer center again. Now, I wanted to spend some time on some of the radiotherapy regimens that we use, because it's not always well understood, and it's something we try to spend a lot of time with patients, but some people think it's magic. How come he got 1 week and someone else got 9 weeks of radiation? So I wanted to go through some of the concerns and definitions of that. So we're going to talk a little bit about radiation fractionation approaches for prostate cancer. And the first one is the standard fractionation, and that's generally 8 to 9 weeks of daily treatments. These treatments are usually 15 to 20 minutes. Patients are in and out of the department, and they do fairly well. Hypofractionated radiotherapy, which we talk a lot about, or sometimes moderately hypofractionated radiotherapy, generally refers to 4 to 5.5 weeks. And then there's SBRT, or sometimes called ultra hypofractionated radiotherapy, and that's delivered over 5 days with either our CyberKnife or our MR-Linac. Some places use regular Linacs, true beams. So it's done different ways in different places, but we have two of the highest quality, top-notch machines with the best data that can be the most precise here. We've got a ViewRay in Delray and the CyberKnife in Boca. And for the most part, the side effects are about the same in all three treatments. Men will get more frequent urination, perhaps urinary frequency, some urgency. Sometimes if they can't make it, you might get some dribbling or slight urgent continence. That's pretty rare, but it can happen. And then sometimes men will get a little bit of urinary burning. Almost always that's pretty mild, where they notice some burning at the tip of the penis. But we have found with the SBRT that it could be slightly worse. I'd say about 5 or 6% of the men will notice that it is much more intense. Sometimes it's even as bad as like peeing glass, they say. So that's probably because the urethra is right in the middle of the field, and the urethra lining is injured, and it takes about 2 weeks for that to heal up. Usually within 2 weeks, men say their symptoms are completely gone with that burning. And again, it's fairly rare. We do have some medications to treat. Sometimes they don't make much of a difference, but we do have some medications to try. And that can happen with any type of radiation. But the data is pretty clear that for the most part, the side effects are minimal and very similar across all three types of radiation, but perhaps slightly worse with the more intense SBRT. So to talk about moderately hyperfractionated radiotherapy, again, 4 to 5.5 weeks of daily radiotherapy. There's strong level 1 evidence now supporting this hypofractionated regimen. There are at least 4 phase 3 randomized trials and many, many more single institution trials out. There was the Prophet trial, the CHIP trial, RTOG trial, and Fox Chase trial that came out several years ago. And they showed that these treatment regimens were equivalent to the standard fractionation regimens that were being used at the time. Some people will argue, well, I usually go higher, or I do it a little bit differently. It doesn't hold up real well compared to what these trials have shown. We still do use standard fractionation. I'll talk about that next. I'll switch to standard. Oh, I didn't talk about standard. We're going right to the other. The standard fractionation is over 8 or 9 weeks. We still do use that for men with very large prostates or who have bad urinary function, the AUA score or IPSS score. If that shows that the men are struggling with weak stream, getting up 4, 5, 6 times a night, frequency all day long and into the evening, those men we know will probably, we want to be a little bit more gentle. We'll use the standard fractionation. And also, traditionally, the NCCN guidelines have shown that we probably should use that for higher risk patients. There is accumulating data now to show that moderately hyperfractionated and SBRT can be used for the unfavorable intermediate and even the high risk patients as well. But traditionally, we've used the standard fractionation. So if there's a combination of a high risk patient and their urination is not so good, almost always I'll use more protracted fractionation. Fractionation just means the number of treatments. So patients will get more treatments. So SBRT is stereotactic body radiotherapy. Some in the past we've called SABR. We're getting a little bit away from this stereotactic ablative radiation. That's what SABR was for. It sounded really cool, but it's not. It's a bit of a misnomer. It's not really ablative. So SBRT is the proper name, and that is the treatment we're referring to when we deliver radiation in 5 treatments or less. There have been numerous excellent trials out supporting SBRT now. One of the first was the HypoRT PC prostate cancer trial. The conclusions of that trial a few years back were that SBRT was non-inferior to conventional fractionation. They first compared it to conventional fractionation and showed that if anything, it may have been a little bit better compared to high risk. Compared to conventional fractionation. And in this trial, it was used for intermediate and high risk prostate cancer patients. Early side effects in this trial were felt to be slightly more pronounced with ultra hypofractionation compared with conventional fractionation, but late toxicity was similar in both groups. And their conclusion was the results support the use of ultra hypofractionation for radiotherapy in prostate cancer. There are a number of PACE trials as well. These are ongoing phase 3, multi-center, multi-cohort randomized controlled studies. These are the ultimate in clinical trials to give us the best evidence to support one treatment over another. These are the most important trials, and they're looking at several different aspects of stereotactic body radiotherapy, this short course of radiation. PACE A compared it to prostatectomy, and there were some conclusions regarding quality of life after SBRT and prostatectomy at 2 years. We don't have the results for efficacy yet, but those should be out in the next year or two as well. PACE B looked at low and favorable intermediate prostate patients with SBRT versus conventional radiotherapy, and none of those patients had ADT. And then PACE C was unfavorable intermediate and high risk patients, and they looked at SBRT versus conventional radiotherapy. The conclusions of the PACE trials so far are that there is now level 1 evidence supporting the safety of SBRT with improved incontinence rates and sexual toxicity compared with prostatectomy. You know, one of the focuses of this, or foci of this talk was supposed to be sexual toxicity and what we can do. Dr. Taub talked on that nicely. Usually it is up to the urologists at the end of the day to address different techniques for erectile dysfunction, but our job is try to avoid it. And generally, with radiation, we do a little bit better than surgery with erectile dysfunction. The bottom line is the way the patient comes in. really affects how they're going to do down the road. So if patients are not very active and if they're not having strong erections, they're at greater risk for having erectile dysfunction after treatment. The radiation can damage the tiny little blood vessels that feed the nerves, and they can, accelerate aging and accelerate the process of development of erectile dysfunction. So that can happen, but generally it happens a little bit less often with radiation, and it also seems to be more amenable to the treatment with the medications, the Viagra and the Cialis, the medications that men sometimes use for erectile dysfunction, and also that you can use to help with urination. The SBRT also is much tighter with the dose. So we're better able to avoid the penile bulb, which we know is very important in radiation causing erectile dysfunction. So we're better able to avoid that. And we're better able to avoid the nerves as well with SBRT because it's so much more precise. So we believe the data with SBRT is better than conventional fractionation. There's also level 1 evidence supporting non-inferiority of SBRT compared to conventional fractionation for failure from biochemical or clinical recurrence of prostate cancer. So that was something we didn't know at first. Is it going to be the same? Is it going to be better? Or is it going to be worse? The general feeling is from data looking at PSA and data, longer term data, that it actually may be better. We have reason to believe that the toxicity may be less ultimately, and the data efficacy may be better. SBRT should be considered as the standard of care for appropriate low and favorable intermediate risk prostate cancer. That was the conclusion of the PACE trials and some of the other randomized controlled studies. So we're getting there, and it started to show up in the NCCN guidelines as well. And SBRT can be delivered on multiple platforms with excellent results. And image guidance is extremely important. That can be done with KV as we do with the CyberKnife. CT is done in many places on machines like the TrueBeam, or MR image guidance like we do with the ViewRay in our Delray office. And again, the conclusions were from these that they're expanding indications. And once again, the tighter margins appear to decrease toxicity, including sexual toxicity. And there was an excellent trial demonstrating this out of UCLA, the Mirage trial. I wanted to say a little bit about rectal spacing as well. That's important because that also helps decrease toxicity, and there's data suggesting that it decreases erectile dysfunction as well. So this is an axial representation, a cross-section representation of what we're talking about. On the left, you see the radiation. Generally, the high-dose region treats the prostate with a margin, usually not quite that big a margin, but you can see that some of that margin goes right through the rectum if the rectal spacing is not done. But when we place the rectal spacer, that white area below the prostate, we are shifting the prostate away from the rectum, and we're able to spare and avoid the rectum. Here's another view on the side. If you look right in the middle, that white area is right below the prostate, and you can see it sitting between the prostate and the rectum. This is the sagittal or side view of that same rectal spacing. And here's what it looks like under the MRI. You can see the spacer here in white, and on the left side there's no spacer, and you can see the prostate sits right next to the prostate. And that's all I have. I'm going to turn it over to Dr. Backow, and will be available for any questions right after the talk.
Perfect. So yes, my name is Dr. Spencer Backow. I'm a medical oncologist and hematologist here at the Lynn Cancer Institute. I specialize in treating patients with advanced genital urinary malignancies, including prostate cancer, bladder cancer, kidney cancer, and testicular cancer. I believe this is my second year doing this. I work very closely with urologists like Dr. Talbot, radiation oncologists like Dr. Casper. We have a wonderful genital urinary multimodality clinic, which I think really provides a lot of benefit for the patients. And we're going to be talking a little bit about just a couple updates in the medical management of recurrent and advanced prostate cancer, with just a touch on management of sexual dysfunction in patients with prostate cancer. So, you heard from Dr. Taub, the urologist. You've heard from Dr. Casper, the radiation oncologist. The standard of care, for the most part, for patients with localized prostate cancer is radical prostatectomy or external beam radiation therapy. And although most patients do very well and they have an excellent progression-free survival and overall survival, some patients do have recurrences, and recurrences can happen in many different forms. Some patients can develop metastatic disease, although that's not very common. It can happen where you can actually have it spread to other parts of the body. Some patients can have early signs of that. We call that biochemical recurrence, where we see a PSA that is rising, but we don't see any evidence of metastatic disease on diagnostic imaging. And the question is, the likely explanation is that the patient has microscopic pieces still in the body that are making the PSA rise. And we know if something is not done at some points, depending on the situation, the patient can develop metastatic disease. So what are some of the options that we discuss at our genitourinary multimodality clinic after somebody has a radical prostatectomy where the prostate gland is surgically removed? You can provide salvage external beam radiation therapy, where the radiation oncologist irradiates the surgical bed where the prostate is removed. And we presume during that time that that is the most likely area where there might be microscopic pieces of prostate cancer are left behind. We a lot of times do salvage radiation therapy in combination with what's called androgen deprivation therapy, or what most people know as hormonal therapy. Testosterone is the male hormone, feeds the male gland, the prostate, and prostate cancer. So by eliminating the testosterone in the blood, this can help sensitize the prostate cancer cells to death from the radiation therapy. And then some people, we can give the hormone therapy intermittently as well, and just kind of create a threshold of how high somebody's PSA gets after they have their radical prostatectomy, give them a hormone shot, watch their PSA go down, and only give it to them again if it goes up again. For patients that have had biochemical recurrence, also known, like I said, as a rising PSA after external beam radiation therapy, salvage radical prostatectomy technically is an option that is not very commonly done. It's more complicated surgically. Focal therapies, which somebody like Dr. Taub would do, which would include high-intensity focused ultrasound or cryotherapy, freezing those certain areas, are available in certain cases as well. And then, of course, medical therapies with androgen deprivation therapy, where we eliminate testosterone. Sometimes we potentiate that with novel hormonal therapies, more advanced next-generation ways of modulating testosterone production and other androgen production. This is a study that I like to quote sometimes, called the EMBARK study design. And this looks at patients that have had biochemical recurrence, either after their radical prostatectomy or their external beam radiation therapy. Now they have a rising PSA. And for these patients, the decision was made to place them on some form of medical therapy, some form of testosterone modulating therapy. And they compared leuprolide, which is our standard androgen deprivation therapy, with a combination of leuprolide with enzalutamide, which is a novel hormonal therapy, versus enzalutamide monotherapy alone. We wanted to ask a lot of different questions in this trial, but one of the things that we like to do is, how can we potentially spare patients some of the additional side effects from androgen deprivation therapy? That would be the leuprolide, such as hot flashes, increased risk for osteoporosis, low libido. Can we just use something like enzalutamide monotherapy and try to avoid some of those? Although enzalutamide can have other side effects, a lot of these hormonal type symptoms, although most men do very well with them, can be somewhat less tolerable. And the metastasis-free survival, so that's the time until a patient develops metastatic disease at 5 years, was greatest for the combination. But interestingly, we saw here that enzalutamide alone, without the leuprolide, without the androgen deprivation therapy, was very good, approximately 80%. So for a lot of patients these days that I want to avoid using androgen deprivation therapy for a variety of different reasons, whether it's a history of cardiac toxicity or the patient's did not tolerate hot flashes previously when they had their primary therapy for their prostate cancer. For instance, if they received hormone therapy for a few months with their radiation, we can use enzalutamide alone. Some other big advances that we see in the medical oncology field for prostate cancer are using PARP inhibitors with androgen receptor pathway inhibitors, also what I've been referring to them as novel hormonal therapies. So what's interesting is that not in most, but in a lot of patients that have recurrent prostate cancer, especially those that are hormone resistant or castrate resistant, approximately 15 to 20% of patients can have genes in a DNA repair path, have mutations in genes in a DNA repair pathway. And we've learned over time that if we give a medication called a PARP inhibitor to those patients that have these genes in that DNA repair pathway, which is called the homologous recombination repair pathway, we can induce remissions in patients for quite a long time. And for the most part, we've only been able to use these for these first several years that we had these agents in patients that had mutations in homologous recombination repair pathway. But we're learning more and more that if we combine it with a novel hormonal therapy or an ARPI, androgen receptor pathway inhibitor, we might be able to sensitize a lot of these patients that don't have these mutations to receive a PARP inhibitor. And then even for the patients that do have these mutations in the homologous recombination repair pathway, we can deepen responses and prolong somebody's remission from their prostate cancer. And there are a variety of FDA-approved combinations of PARP inhibitors and androgen receptor pathway inhibitors, including olaparib and abiraterone, niraparib and abiraterone, and talazoparib and enzalutamide. We see improved progression-free survival benefits. These increased response rates and improved progression-free survival benefits are most notable in patients that have mutations in the homologous recombination repair pathway. But we are seeing responses in patients that don't have these options, and that don't have those mutations. And this is just an example of how the treatment of advanced cancer is becoming more personalized at this point. Another big update that we've had in patients with metastatic pretreated hormone-resistant prostate cancer is the use of PSMA technology. So PSMA stands for prostate-specific membrane antigen. As you can see from the graph on the left, if you could look really closely, PSMA is highly expressed at the cell surface of patients with prostate cancer as compared to other organs. So the question is, can we develop a therapy that targets this unique antigen that's only seen in PSMA patients? And because PSMA is not highly expressed in other tissues and organs, we would have less toxicity and less effect on potentially the other organs. And we've been able to take advantage of this from both a diagnostic and therapeutic perspective. We now have molecular imaging that we use for patients with prostate cancer. We call them PSMA PET scans, where we take an antibody that binds to PSMA, or prostate-specific membrane antigen, and we put a little piece of radiation on it and we inject it into the patient, and then we use our PET CT scanner, and it's highly sensitive and specific for finding metastatic and recurrent prostate cancer compared to conventional imaging, which would be CT scan or nuclear medicine bone scans. It's really helped us make better decisions for our patients with rising PSAs after definitive therapy for their prostate cancer, whether it's radical prostatectomy or whether it's external beam radiation therapy. We've been able to take it a step further. So we've learned how to use PSMA to make a diagnostic imaging modality, but we've also learned how to make it into a therapy. And there is now a medication called Pluvicto, that's the trade name, or lutetium-177 PSMA. It is an anti-PSMA antibody with a piece of radioactive lutetium on it, and it's taken up by the prostate cancer cells by binding to the PSMA, as shown by the figure on the left. It is endocytosed, which means it's taken up into the cell, and then it is released into the cytosol, and it goes into the nucleus of the cell and causes DNA damage, and the cell cannot repair the DNA, and then it undergoes the cell suicide program. And Pluvicto was approved by the FDA for the patients with metastatic castrate-resistant prostate cancers that have previously received a taxane chemotherapy and one of those novel hormonal therapies or androgen receptor pathway inhibitors based on this trial called the Vision trial. And patients were randomized to standard of care, which would include additional chemotherapy or other hormonal modulating agents, or receiving the Pluvicto, which is the lutetium-177 PSMA. And this is just an example of a patient that received Pluvicto. These are PSMA PET scans, and you can see with the radiograph on the left, there is widespread metastatic prostate cancer in this patient throughout most of the bones, predominantly in the ribs, the axial and proximal appendicular skeletons as well. After one cycle of Pluvicto in the middle radiograph here, you can see a lot of those metastatic lesions are starting to resolve. And after 2 cycles of anti-PSMA targeted therapy with the Pluvicto, we see a near complete remission. And this is a treatment modality that has allowed us to put a lot of our patients into longer term remissions than we previously have with prostate cancer, with advanced prostate cancer. It's now moved up the approval, so you don't have to have had chemotherapy now in order to get Pluvicto. And we're exploring rational combinations of Pluvicto with other agents, newer agents, older agents, to see if we can deepen the response, prolong the remission, and then, of course, achieve our ultimate goal, improving overall survival for patients with advanced prostate cancer. I know Dr. Taub and briefly Dr. Casper briefly touched on sexual dysfunction in prostate cancer, and you can really think of it in 2 categories. One is erectile dysfunction, and one is low libido. And a low libido is something I see very commonly in my clinic because low libido results from states of what we call hypogonadism, states of chronically low testosterone. And the hormone shot and a lot of these hormone pills can cause it and can have an obvious impact on quality of life. Obviously, lifestyle changes such as exercise and stress reduction can help. Medications such as sildenafil or Viagra, Cialis, Tadalafil, those can help with the erectile dysfunction, but a lot of times that does not help somewhat with the underlying decrease in libido. And that is something that I think the urology community is still working on at this time. We don't like to give testosterone to patients to help with the low libido because we're always worried that we're going to add fuel to the fire. But it is an area of, I believe, an area of more research and an area of unmet need in patients with advanced prostate cancer that are on chronic hormonal therapies is the low libido. The erectile dysfunction, a lot of it can be helped with a lot of the pills I talked about, the phosphodiesterase inhibitors. There are other modalities such as the trimix where you could inject those medications directly into the base of the penis. And then there are surgical procedures such as penile implants as well that can help with erectile dysfunction. And those are all, I kept it short and sweet. Those are all my slides for today.
Wow. Thank you, doctors. There is one question in the chat box. Can you all see it? I don't know who it would be addressed to. What a Gleason score? That be Dr.
It
Taub?
says hypothetical situation, 70-year-old male in otherwise good health with 2 Gleason 6 and 1 Gleason 7 with a favorable Polaris score. PSA rose from less than 2 to 11 over the course of 12 months. How do you decide between the options? Very good case, one that we see very commonly in our tumor conference.
Yeah, I mean, it's again a conversation, and Dr. Casper really touched on the value of our multimodality clinic. The 2 to 11 is concerning. Sometimes rechecking the PSA goes back down, and it's 4 or 5. That seems more reasonable. But if active surveillance is an option, which it may be, then potentially repeat MRI, repeat biopsy is in order. Otherwise, surgery and radiation are probably both great options too.
One thing that wasn't mentioned is whether or not there was an MRI done and whether this was an MRI guided biopsy. One of the real strengths of our program, I see compared to outside areas sometimes, are that we're using almost exclusively MR guided biopsies, unless there's no MR findings. And we have a lot more confidence in the diagnosis that this truly would be a Gleason's 6 and Gleason's 7 if an MRI guided biopsy was done. But if it was a transrectal ultrasound, we're not sure. We really don't know.
Good point.
Thank you. Are there any other questions? Looks like I think everything was covered so thoroughly, there probably are not very many questions. And thank you, doctors. This was amazing. And we all learned so much from you today. And as I said in the beginning, this really is a lecture for everyone, obviously for the men, but for all of us ladies, that we guide the men in our lives and encourage them to follow up with this kind of care. This lecture was recorded, so if you would like to look at it again, or if you'd like to share it with any family or friends, coworkers, when Lee sends you the evaluation, probably later today or Monday, we should have the lecture ready, and she will send you a link so that you can watch or share this lecture again. We do encourage everyone to complete the evaluation. It helps us. Many people give us ideas of what kind of lectures you'd like to hear. And it also encourages our speakers and recognizes that we appreciate the generosity of each of you, your time and expertise, and we know how much it goes into research for this and putting it together on top of the beautiful care that you give to your patients. So thank you all very much. Our next presentation on our series will be Wednesday, September 17th. It will be from our nutrition series. And Marie Miranda, our clinical dietitian, will be presenting on men's health. So thank you, doctors. Thank you, everyone who joined us, and have a great weekend, everyone.
Thank you.
Thank you.